Dr. Parth SHAH. Craig Donaldson did not come. He couldn't come, so we have someone from Australia, so with Indian roots, so we do have. So
he's from Pittsburgh. He's not from Australia.
Presentation, please.
This side, this side.
That's okay. I can move that.
No, Parth, they want to do it from here. Presentation shuru kar do, please.
Thanks very much for the opportunity to present. This is a technique that's been recently published, and this was a case that I was involved with Professor Ken Nischel during my fellowship. It demonstrates a technique for the management of extensive lipodermoid and limbal dermoid in children. So the first step was an examination under anesthesia. The next stage is to debulk the conjunctival lipodermoid component. I think it's not very smooth, but anyway, the videos come out a bit unusual. But so yes, so debulking the lipodermoid component as an initial surgery, and then 6 weeks later doing the limbal dermoid excision with SLET, so simple limbal epithelial transplant. The benefit of this technique is that it avoids the need for a corneal transplant in these children, and rapid epithelial corneal healing with the SLET procedure. So we had the benefit of having the intraoperative OCT in Pittsburgh, which I hope some of you may also have available here in India, but a careful dissection of the large limbal dermoid and checking the residual corneal bed. And you know, this is a 3-minute video, but it does take time to do this properly and safely. And so the whole corneal, like you can tell that this is a very large limbal dermoid. The entire lesion has been removed, and the bed will be polished with a diamond burr. The conjunctiva is sutured with a recession on the episclera. Conjunctival autograft is placed, and then a 2mm slit is performed from the same eye. So the other benefit of this procedure that it avoids needing to operate or touch the fellow eye, which usually in these children will be the much better seeing eye for the rest of their life. And then the slit is harvested and then secured with glue to the cornea. That helps with rapid epithelial healing. The conjunctiva is also secured with glue and a couple of sutures, and a large bandage contact lens is placed. Because of the large step, that's just smoothened with Vanna's scissors and a diamond burr. And in all of these cases, we perform a temporary tarsorrhaphy using a technique which we've also published in another paper on keratoconus management. So that's probably pause it there if I can, just to, oh, it's gone. Just to show the before and after. I'm not sure if I can take it back.
I think.
Let's go.
All right. Okay, thank you.
Thank you.
So how many people feel comfortable doing an SLET, that simple limbal epithelial transplant? It is a very simple procedure described from the LV Prasad Cornea group some years ago, and they used it to describe for epithelial regrowth after alkali burns in the other eye. But we showed now that there's some stromal regeneration as well. So as Parth said, you don't have to use a corneal transplant necessarily. Parth, if people are going to do this for the first time,
yep.
Do you have any advice?
I think like when performing the whole procedure or the SLET itself?
I think the whole procedure.
Yeah, I think the whole procedure, I think the exam under anesthesia is very critical to identify, and if you have an anterior segment OCT, either intraop or a handheld one, that you can assess the corneal depth to ensure that it's well clear of decimates. I think that's very helpful and to plan. And then I think just taking time, because you know, it's sort of like doing a really, really advanced pterygium, but a lot deeper and a lot bigger and more bulky. And so I think taking a lot of time is also very important.
And do you do it in 2 stages or 1 stage? So do you do the lipodermoid first
Yes.
and then come back a few weeks later?
Yeah, 6 weeks later.
Yeah.
Yeah.
Anybody had any? Yes, go ahead. Remember to say who you are and where you're from.
I was playing again. I'll show you the...
Yeah, they'll show you. And this is published, so if you want to know the details,
yes,
it is published.
Yeah.
I'm Dr. Manjula from Chennai. How
Manjula.
much should be the corneal bed, the residual corneal bed, for you to do a slit as opposed to a lamella K-plasty?
Yeah, I guess it's difficult to quantify the exact corneal depth on the intraoperative OCT, but in this situation, we could tell that there was at least 40% of the corneal bed remaining.
It was a bit more. It's about 250 is your
250.
limit. Anything less than 250, then I think I would do a lamella keratoplasty. But, sorry?
On-table pachymetry?
No, we use the OCT.
We use the OCT to estimate.
Yeah.
Yeah.
It is worth having, if you are ever in a situation where you can't get graft material, it is worth knowing that you can do that. And if Parth was saying, if you look at the before and after, it's really quite dramatic. In fact, almost all my dermoid removals now, even the ones that I shave, I'll put a little bit of slat on because you get no scarring. It's really quite nice. So how much is the astigmatism?
This child had, from memory, about 6 diopters of astigmatism. But after post-operatively, when we got her into glasses, she was seeing a lot better because it's a lot less irregular than it used to be.
Yeah, she still has astigmatism, but you could put a contact lens on. That's the difference. Okay, we'll have any other... Good. We got it. Naomi, go ahead.
Thanks, lovely video. 2 quick questions. What was your on-table OCT your pre-op EUA examination, or had you done a separate examination to look at the depth before you started?
I was on table. We didn't examine under anesthesia initially when we could do that, and then intraoperatively during the actual excision as well.
Okay. And the second one is, what's your threshold for removing a limbal dermoid? Smaller ones that aren't quite so visually significant.
So I think it really depends on, they can be highly symptomatic as well if they're close to the lid margin and if they're affecting vision and if we think that the irregularity is contributing to amblyopia. I think they're the 2 main things.
Can I answer one thing about your second question? And I actually have a patient that I sent to Dr. Nishal who I saw in the NICU. I was called the first day to see this patient was with golden Haar with a humongous limbal dermoid. So actually going all over the visual axis. And I was like, there's no way this patient can get a better vision than counting fingers. And now this patient is 6 years old and she has a 20/40 vision with aggressive therapy, amblyopia therapy, glasses, but what a fabulous procedure that you've done.
I will pay you later, whatever meal you want.
I was planted.